screening test that I usually use for, again, for determining whether there's a cervical spine involvement for patients with facial pain. So in this case, usually when you rotate your head towards the right, that would provoke more of a of pain on the right side, and then vice versa. Okay, so again, some of those things you need to include in your assessment. All right, so examination. Again, this I won't go so much detail, but these are things that you need to include in your assessment. Okay, so after cervical spine screening, you want to look at posture and structural. Okay, now we're looking at this. We're observing now and looking at the structure of their entire mouth. Okay, or their jaw, their mouth, and so you want to see if they have excessive forward head posture, and you want to find out if neck protrusion is affecting their TMJ. Okay, so a lot of times, for patients, if you have them protrude their head, that provokes the pain here. If they retract, it reduces the pain here. Okay, so facial profile, look at the head alignment, tongue position at rest, tip of tongue on roof of your mouth. Okay, these are, and later on when we'll look into the incorporating breathing patterns and prescribing motor exercises to improve motor control. I'm going to show you how it's done using the tongue position at rest. Okay, so dental exam, again, not probably part of our practice, but we need to find out they have any missing teeth. Okay, so full set of teeth is 32. You have 16 upper and 16 lower. So you want to ask those patients if they're missing any tooth. Does the patient also exhibit a bite classification? So a bite classification would be, again, a structural observation. Okay, class 1 occlusion is normal. Class 2 occlusion is an overbite. And class 3 occlusion is an underbite. So what it looks like is this. So class 1 occlusion, normal. All right, so I say everybody knows Jay Leno here. What bite classification does he exhibit? This is Jay Leno, and this guy over here is the former dictator of Syria, President Assad. Anyway, okay, class 2 occlusion. Who is it? Class 2 occlusion is class 2 occlusion is overbite. Okay, so this is class 3 occlusion. Jay Leno is class 2 occlusion. Okay, so a lot of things when you just document them in your initial eval, and later on you want to see if any of these is relevant. Okay, in the condition. All right. So in summary, okay, looking at the neck, the TMJ, and then that entire and pretty much head alignment, neck alignment, things like that. This is just really a picture. Then this was from Teresa's slide. Head and neck dysfunction can again contribute to a TMJ disorder. Occlusal disharmony simply means, okay, they have things in, it's a dental problem. Okay, if that both can contribute to a TMJ problem, coupled with a muscle imbalance issue. Okay, and when I say muscle imbalance, we're talking about patient looking at the muscle attachment of the entire muscular system in the whole craniomandibular region to see if some muscles are short and tight, or some of the muscles which are long and weak. Okay, so again, to give you an example, a patient who has a forward head posture, okay, having a headache, okay, a cervical headache, will have suboccipital muscles which are short and tight. And which part of the neck is long and weak? They're usually your deep neck flexors. Okay, so these are all contributory to a TMJ disorder. A lot of things that we need to sort out in your examination process, but I guess it gives you, hopefully this again gives you a starting point to work on. And your treatment goal obviously is neuromuscular harmony. So you want everything is happy, okay? You need everything happy. Okay, I'm gonna pause for a little, this is basically just a halftime break, okay? I have 15 more slides to go after this, but before I continue, again, I want to answer a few of your questions if you have. So I'm gonna just have a few minutes to answer those questions, okay? So for our moderator, Isabel, if there are any questions from the audience, I'll be happy to answer.
Yes, there's actually a question already, Andre. From Anonymous. Thank you for highlighting this topic. A bulk of ENT and dentists are starting to refer patients to me in the province. You gave me a good template in mind how to manage such cases. Is there a clinical practice guidelines for TMJ you can recommend?
Yeah, good question. Not that I know of that. Okay, so clinical practice guidelines, we have a lot of clinical practice guidelines for different musculoskeletal conditions, okay, developed by the American Academy of Orthopedic Physical Therapy, okay, or Academy of Orthopedic Physical Therapy, which is the subsection of the American PT Association, okay, in orthopedics, so it's an orthopedic section. They develop a lot of clinical practice guidelines. As far as I know, there is none that is directly on the TMJ that is exclusively for the TMJ, but there is one for the cervical spine. Now, having said that, you want to start looking into the clinical practice guidelines for neck pain. Okay. Now, obviously, it talks about primarily neck pain, but it also talks about neck pain with headache, and that would be a starting point for you to develop your I would say your expertise in the topic. But as far as the TMJ exclusively, I don't think there is.
Okay.
Any more questions?
There was a question about wisdom tooth extraction, but you already answered that. But that's it. No other questions were sent to me.
Okay, thank you. Okay, let's continue. All right, so very important. All right, how do we measure mouth opening? Okay, so these are all just basic components of your physical exam now. Now, normal mouth opening is actually 40 millimeters. That's about 2 to 3 fingers width. Now, if everyone, I'd like everyone to measure their mouth opening, especially those participants who are having pain with maximal mouth opening. Okay, I want to let me know what you find as you open your mouth as wide as you can and try to fit 2 knuckles in first. Okay? In my case, like for me, I can only fit 2 knuckles in, but that's still the normal range. For some people who have a really excessive amount of movement in their jaw, I wouldn't necessarily call it hypermobile, but they have basically they can expand their jaw as far as 3 knuckles. Okay, so the range would be from 40 to 55 millimeters. Now there's a scale, as a range of motion scale that is available, and I'm pretty sure you can get this. It's called, and this is just the brand. It's called Therabyte Range of Motion Scale. If you ask any of your dentists, they probably have this. I'm not sure, but you can actually order this for your clinic as well. They're basically just cut off pieces of paper actually, and this is disposable. So make sure. Now there is actually a scale that's actually made of, I think it's steel. Okay, so just make sure when you measure each person, okay, always disinfect this whole piece. Okay, I usually get the disposable one, so after each use, I just throw them away. Okay, so that's another way you can measure your mouth opening up to the millimeter, on a millimeter scale. If not, I usually, again, if I don't have that, you can also use your goniometer, okay, by measuring from the top of the incisors and the lower incisor, the opening. You can also use your goniometer for that. Okay. Okay, so where are we now? Okay, lateral excursion. Okay, So that's another way. How to measure it is usually 1/4 of normal is 1/4 measurement of mouth opening. So it's usually like 10 millimeters using the range of motion scale on each direction. Okay. So what I usually do here is, again, aside from measuring, you can have the patient roll up this gauze made of piece of gauze roll made of gauze, and then have them bite into it, because you basically want have your mouth slightly open, okay, and then measure it, because you technically can't measure lateral excursion with your mouth wide open, okay. So if you do that, you'll have less range, okay. Your joint has to be in a resting position for you to be able to measure lateral excursion effectively. Okay? So the line between your mandibular and center incisors to the line between your maxillary center incisors when the mandible is moved lateral. So that's how you measure. Okay, so normal range is 10 millimeters. All right, retrusion and protrusion again is a movement, okay, of the lower jaw. Okay, easy to follow that. Okay, so another part of the assessment is looking at passive range of motion. Okay, so we know passive range of motion is basically bringing the joint into its to the end range. But as far as as a practitioner specializing in this, you'll need to you will need to learn how to do a joint play assessment. Okay, the purpose of doing a joint play assessment is to appreciate movement and well, most importantly, we need to find out if symptoms are produced when we do a joint assessment. So passive overpressure is also a part of the passive range of motion assessment. And by doing overpressure, you can load the TMJ, and then you can assess for pain in both directions. So I think I'm going to show you here, okay, in our model, okay, we're showing a model. So how do we do a joint play assessment when you're basically going to, you won't be able to see the picture in this drawing, but actually what I'm going to do is always have a exam glove. Never put your dirty hands on a patient's mouth. Okay, so you always want to, you have a box of gloves handy. Okay, so basically what you want to do, if you can see this in my screen, okay, so what you're going to do is how to position yourself is you're going to cup the patient's head, okay, on top, okay, and have them close to you as much as possible. So you want to make sure that they don't move around and everything. So for usually some females what they do is they put a pillow here if they have a male patient, and then bring that here. Okay, can you see that? Okay, so basically when you go joint assessment, okay, have them open their mouth. Okay, although my model here, this is a spring-loaded jaw model, so I need to separate that to show you. Okay, so you want to put your thumb in. Okay, slide them in. Okay, and then to do a joint play assessment, you can distract the joint. Okay, I want to see if you have any, and ask the patient if you have any pain in that movement. Okay, and I also can translate. So when you translate, and this would be part of your mobilization technique, which I'll show you in a bit when I'm on a video, but basically what you're going to do is you look for pain response, distraction, translation. Okay. Okay, now how about symptoms? Are there symptoms produced with overpressure? So what you do is you basically just apply pressure on the mandible superiorly to compress the joint. Okay, so for one of the participants who have a pain when they were opening their mouth, try to compress the joint. Now it's painful when you open your mouth widely, but what happens if you compress the joint? So I want to find out if you have that. If you have pain when compressing the joint or when biting, There are two things that can happen. You can have a masticatory problem or a joint arthralgia. Oh, so again, I don't want to confuse you with a lot of these terminologies. So if you have pain when with opening your mouth widely and closing your mouth, biting into that side of the jaw, there's two things that can happen. You can have a joint problem or you can have a muscle problem. Okay, so we need to differentiate that later on through our assessment. All right, so little review on the muscles of mastication. Okay, so we have four muscles of mastication. You have the temporalis muscle, your masseters, and your medial pterygoid and lateral pterygoid muscles. Okay, so in that, in that picture there. Now, part of the assessments for a muscle, aside from just testing their strength, and keep in mind that actually, I normally don't test how strong you can bite. I don't think that's, unless they have some kind of a systemic issue, but I never test the strength of a patient's bite. First of all, it's really, I don't think it's necessary. They can overpower you and just bite your finger off, basically, when you do that. But there are several things you can do to see how well they can hold a contraction. Okay, so it could be a muscle, it could be an isometric contraction. Okay, so there are things you can do here. Now, I gotta also remember, like, you need to know also what these muscles are. So your temporalis, masseters, and your medial pterygoids are actually the main or the prime movers of jaw or jaw elevation. Okay, so bite. Okay, so temporalis, masseter, medial pterygoids. Okay, for jaw elevation. Okay, and you'll have your lateral pterygoids as a prime mover for protrusion. Okay, so that's the main function of your lateral pterygoids, which also they also assist with chewing, because again, when you chew, the act of chewing is not only this. Okay, when you chew big chunks of food, your jaw has to be able to protrude. To go into protrusion, it has to be able to actually deviate laterally too. Okay, so that whole chewing motion. Now, what are the muscles responsible for jaw depression, mouth opening? So those muscles are actually your hyoid group, digastric, and your platysma, all located into your neck. Okay. So there you go. This is another picture you have there, which hyoid group, digastric, and your platysma. I think I forgot to add platysma here, but those are the muscle groups responsible for mouth opening and closing. All right, so to continue your muscle performance testing, okay, so you want to test all of these movements. So how do we test protrusion? So typically what you do with testing protrusion is actually just resisting the patient's chin. Okay, so they're going to go against resistance. So you can test that to see if it reproduces their pain or their jaw. Okay, lateral excursion, same thing. You're going to apply pressure on the lateral aspect of your chin and then have the patient laterally deviate the jaw. And for mouth opening, okay, usually for mouth opening, what we do is we basically just apply. You have to stand behind your patient. Okay, when you stand behind your patient, you're going to get your arms around and then apply a resistive force when their mouth. You always want to start in a resting position. So what I typically tell patients is, I want you to bring your tongue to the roof of your mouth, and in that position, I want you to open or drop your jaw. Okay, so try to open your mouth against my resistance. You're not really overpowering. Remember, mouth opening, the force required for mouth opening is not as intense as the forces required for mouth closing. So not for which is needed for chewing food and grinding food. So for mouth closing, what you do is you resist the jaw from the superior part or the top portion of your chin. Okay, so you're still behind the patient and using your thumbs to apply a downward directed force for them to be able to, do the test. So for deep neck flexors, you want to include this as well in your muscle performance testing. So an endurance test for deep neck flexors. I don't have a video here, but basically what this does, this is a test we also do for cervicogenic headache, okay, or neck pain, okay, which is an association as well for patients who have headaches and neck pain. There's an association of, or I would say, a component of weakness in their deep neck flexors and anterior neck muscles and that's good to test also as far as your examination. So usually for an endurance test, what we do here is we lift, we basically have the patient relax first, okay? They're in supine. When lift the head up just gently off the mat, okay? But they have to, you have to instruct them to tuck their chin in, okay? Bring their chin in towards your throat. So they're almost doing like a double chin here. Now, and this is very important to when you do this correctly in a clinic, it's very important to, you have to look at different things here in order to make the test valid, okay? So just for this, an endurance test with 39 seconds for asymptomatic individuals is actually good. And for patients with, again, symptoms, that could be neck pain or pain around the, I would say even the face, you'll have a 24-second a normal value for that, okay? But what you're trying to see here is they should be able to maintain that position without fatigue, okay? So in the clinic, we can look at that, okay, just observing how they can hold that neck in that position, and then and then document the findings, okay, or the results. All right, so we already showed this here earlier. Lateral excursion, left lateral excursion. That's how you want to. A lot of this is all isometrics, okay. So if you're thinking if you're planning on a management or giving patients some of these home exercises, okay, for as far as I would say strengthening, okay, because a lot of times you won't really, if they're in pain, obviously they'll have muscle guarding and all those things. So you'll have to see if you can reduce their symptoms first before being able to do this exercise for home. So a lot of times if you start giving them, if you're not addressing the pain issues or pain factor, and then start giving them this could lead to overuse, okay, of their masticatory muscles. So you have very, very important to decide. You have to determine when to give this exercises to your patients. Okay, so palpation of the TMJ and masticatory muscles. We need to know landmarks, okay? So your external auditory meatus, basically that's your inner ear, okay? So the opening of your ear. So you have, document this in your initial eval, okay? So palpation is also important for patients with facial pain or TMJ pain. So you want to know exactly where you're palpating, what muscle groups they are, okay? So when you're preauricular area, and I want everybody to actually palpate their preauricular area, which is basically the area of your TMJ. So what you do, and I guess everybody can know where the TMJ is, but in order to appreciate movement, and sometimes you'll be able to palpate some, especially for patients who have a disc displacement or disc derangement, they'll have, aside from the auditory click or popping that they complain about, you'll have to try to see if you can feel any abnormal movement. Okay, so your preauricular area is basically the area on front of your ear. Okay, So if you actually palpate that, you'll have a bony landmark, and you'll just go probably posterior to that region. And I want you to open and close your mouth. Okay, you'll see if you open your mouth, you'll feel an indentation. Okay, you'll feel your finger go in, and that's the region of your TMJ, the posterior part of your TMJ. Okay, so what are we palpating when we do an exam? Okay, so the key muscles to look for when you're palpating, which are again sources of pain, referred pain. Okay, and when I say referred pain, we're talking about trigger points now, and temporalis. Okay, so when you're doing an assessment, okay, patients have to be relaxed. They're in supine. You'll be on front of them or on the back. Okay, and you're going to look at tender points. Okay, so make sure you're actually applying some pressure, because a lot of times trigger points can happen not in the belly of the muscle. Most of the time it is there, but you can also look where, you want to go through the entire muscle belly all the way to where they're towards the insertion of the muscle. Okay, so temporalis, masseters, and the pterygoids. Okay, so how to palpate the pterygoids? The medial pterygoid, this diagram down here is the area where you want to palpate your pterygoids, your medial pterygoid. So basically, it's the area just immediately below your posterior part of your jaw. Okay, so that area is actually sensitive. Okay, for a lot of patients. So you just be very careful when you palpate that area. Now you're not really looking at, all right, you're not digging all the way in, because remember, that's painful. Just myself, I'm putting pressure on that area. If you hit the anterior part of your neck all the way in, that is very painful. So for patients who have potential trigger points, a little pressure there is going to, light up their symptoms. And keep in mind that trigger points can actually, trigger points can refer, okay, can produce pain in the facial region, right? So we have to, that's part of the examination process. It can be tender in that whole area, but it can also produce pain in different parts of the face. So check for pain and for trigger points. All right, so this is another, again, a nice diagram. Key muscles to look for, if you're looking for trigger points, is your sternocleidomastoid, okay, and your again, this is just one diagram, and this was first described by Jeanette Travell in the 1960s. She was an American physician, and who had pioneered a lot of work on trigger points and management, okay, of muscle disorders, muscle pain from muscle trigger points by, again, I'll be discussing some of the treatment options later on, but again, these are, we recognize that trigger points can produce pain in remote areas of the body. Okay? So check for this sternocleidomastoid, splenius semispinalis muscles, okay, in that area. Now, also, when we're considering a cervical spine involvement, we know that your zygomorphofacial facet joints can actually refer pain to the two areas of the face. Okay, so you're looking at C2, C3. Now, again, that would be part of your examination process to see if there's any referred patterns from the neck or for the cervical spine. Sorry. All right, so we have a case here, and after this case, again, this is actually a pretty straightforward, simple case. I have this patient on, I'm currently treating this patient, and we've had great success. I've had great success as far as meeting her goals. And after this a little case vignette presentation, I'm going to ask you a question which you're going to answer in the poll. So I have a patient who's a 53-year-old female with a chief complaint of mild pain in her left TMJ. Okay, so patient states that symptoms started after a dental procedure 2 years ago. Okay, she reports symptoms are intermittent and unchanging. So look at this whole history first. You have a patient, okay, who's a little bit above the prevalence of TMJ disorders. She's 53, and her pain is very localized to the jaw. Okay, the TMJ, which tells us, okay, it could be a local problem. Okay, it's intermittent, meaning, okay, it could be a mechanical problem too. Now you have the mechanism of injury would be I wouldn't say mechanism, but this would be an event that predisposed her her symptoms. She had a dental procedure 2 years ago, so she told me she just remembers having a dental procedure, and a few days later she started having pain in that left TMJ. Now, keep in mind, this happened 2 years ago. Her symptoms have since improved, but her main functional limitation is loss of or inability to open her mouth wide. Okay, so, and that's been going on for 2 years. Now, part of the problem is when I asked her, okay, are you limiting your ability to, or your mouth opening? And she said yes. She has a fear of opening her mouth that wide because it hurts. So she's been basically just moving her jaw where it feels happy, basically, to put it that way. There's no joint clicking, so which tells us the patient does not have a disc derangement or a disc displacement. I asked her several questions on parafunctions. Okay, if you remember parafunctions, she does not have any detrimental oral habits. Okay, although she tells me she started, she used a mouth guard because she felt like, and I don't know if this was consistent, that she has grinding, okay, which is called bruxism. Okay, grinding at night. Okay, a lot of patients with the TMJ disorders have grinding. Okay, so one of the dental appliances that are prescribed to patients with bruxism is actually having a mouth guard. Okay, at night. So basically, what it does is it separates your teeth while you're sleeping. Okay, prevents you from grinding. Now, teeth inspection, you have full. There's no missing teeth. Bite classification, normal. Posture, you will say it's normal. She's really have good posture. She's actually a yoga instructor, so just nothing there that I can comment on. Does she have a history of neck pain? She does have neck pain, but again, this is where you want to know when patients tell you they have a history of neck pain. You want to know immediately what you want to find out is where was her neck pain. Okay, where did she have symptoms in her neck? Okay, so if she had symptoms down the neck, well and good. Okay, you can probably discern from that okay, that's probably not contributing to her pain. But if they start having, they tell you they have a neck pain with a headache, okay, unilateral, okay, usually one side and things like that. That's when you start looking into the cervical spine more in detail. Okay, so for a cervical headache, she does not have a cervical headache. Mouth opening. Okay, she basically was able to fit in two fingers when we first started, but again, for her that's not normal. Okay, because she tells me she can fit her two knuckles in, but she feels a tight band around on her jaw, okay, around the TMJ. So which tells me, okay, something is not normal. Okay, so we want to see if we can address that. Right and left lateral excursion was within normal limits, and protrusion, okay, was also within normal limits. Now, I want to ask everyone now, what is your provisional diagnosis? So what I want you to tell me is it a muscle problem? Is it a joint problem? Or is it a CNS pathology? Very good. All right, so most of you, 51%, responded that it is a masticatory muscle disorder. Okay, so yes. Now this is interesting here, because a lot of times when patients have a muscle problem or masticatory muscle disorder, that can affect joint function also. Okay, do you all agree? Okay, because basically your muscles can open the joint as far as your joint can take it. But again, you can have a joint problem, okay, on its own exclusive. But normally when you start having a masticatory muscle problem, okay, that can affect joint motion too. So the inability to open the mouth could be restricted by the muscles. Okay, you could have shortened muscles, or you could have, because again, your joint capsule, okay, which is your passive restraint, can also be affected. Now for her, since they don't, because the patient does not have any clicking, popping, or anything like that, then it tells me, okay, well, she probably doesn't have a joint problem. Okay, it could be something else. It could be the joint capsule too, because mouth opening extends the joint capsule, and if you have limitations, that's one of the things that you can ask is, and this is more going into really the you're trying to tease into the whole problem now. For me to determine whether it's a capsular problem is loss of movement. And when you stretch a joint capsule, you usually have pain. Okay, so for this patient, she only has pain when she opens her mouth as wide or taking, as wide as possible. She doesn't have pain with normal, relaxed movements of the jaw. Okay, she only has pain when she opens her mouth. Now, to further investigate to see if it's a joint problem, okay, you'll need to do a compressive test. Okay, so I would consider this more of a special test. Okay, so what you want to do is, so you'll have to have 2 tongue depressors, or maybe just 1. Okay, so what you want to do is have the patient bite. So for this patient, her problem was in her left TMJ, right? So basically, I'll have her bite into the left molar. Okay. Yeah. So this is the position of the, okay. Now, if she bites into the tongue depressor and starts having pain, that will lead into a muscle problem, okay? Because why? Because your joint is not fully compressed, as opposed to having her bite on that jaw and then pain. So you'll have to see which is more painful, or which produces pain and which produces or does not produce pain. So if they have pain when biting into the tongue depressor, that will lead you to think of a muscle problem. Okay, are you all following me? Okay, so a little bit here. Again, just 2 conditions, competing diagnoses, okay? Masticatory or a joint. So for your history, you'll have a history of overuse and fair functions for patients who have a masticatory problem, okay? Now, for a joint disorder, you'll have trauma, usually macro trauma. Okay, so for this patient that I just presented, my thought process is it started as a joint problem, okay? Because again, she tells you it's improved. It has improved in the last 2 years. But the problem is she starts having pain only when she opens her mouth. But again, you always can tighten your muscles there, but you have to just know what to do next, okay, as far as treatment. Because basically, at the end of the day, you're trying to treat the impairment, okay? But again, it gives you an idea that, okay, well, it is a joint problem. It is a muscle problem that's limiting joint opening. So patients can have 2 conditions going on at the same time. The only thing that really separates a joint problem or a muscle problem is the presence of clicking and tapping, okay? And muscles may deviate to one side when you observe mouth opening. For her, in her case, she has normal movements of her jaw. So neither jaw deviates to one side or not. So again, because of the, I won't be able to include, an explanation, or again, an explanation of a patient having developed, with a joint disorder. But these are other things that you will look at when we hopefully, attend the courses that we are offering in Craniomandibular. So we'll talk more of that in detail. So for palpation, for masticatory muscle disorders, you'll have trigger points, and for joint disorders, you'll have preauricular pain. So for this patient, she does not have that. Okay, palpating the posterior aspect of TMJ does not produce pain with mouth opening and closing. Now, associated findings for muscle disorders, you'll have a cervical spine component. For joint disorder, yes, you can also have a cervical spine component. But again, these are all feeding into the entire, feeding into the patient's symptoms. Okay, very good. I hope this is not too confusing. Again, it just takes time to absorb all these details, okay? Especially for those who are new into the assessment of TMJ disorders. But again, it's really, really easy. Just think about, is it a muscle problem or a joint problem? Okay? At this point of presentation, that's all you want to focus on. Okay, so this is probably the part where I do my best to show you some videos of techniques. Okay, and in the actual course itself of our Craniomandibular course, we're going to show or teach you, more than these. There's so much involved in that 2-day course because again, the entire day of our 2-day Craniomandibular course includes assessment of the upper cervical spine. And for those, for our participants who have taken our cervical thoracic course by Dr. Ulysses Funcilla, he includes the upper cervical and treatment for headaches, cervical headaches in his course. So this Craniomandibular course would be the advanced portion of these of the cervical spine per se. But again, I think as a standalone course, I think all PT should be able to attend this course as a standalone, and we can talk more on all of those things. So I'm going to show you five techniques. Okay, 3 of these techniques are 1, 2, 3 are actually we made video clips on it. So that will show you more of the movement involved. Okay, so again, all right, the TMJ distraction here. All right, again, thanks to my colleague Teresa Carrillo. Again, I know I filmed this video as part of our course when we first taught this in 2014. And again, I was just a lab assistant then, but I learned a lot as, in at least teaching it to the beginner level. And I also say this, I don't see as many TMJ patients that I would like to in my practice because I'm still more of a general orthopedic PT practitioner and an OMPT practitioner, but we get a few referrals from different doctors requesting a TMJ evaluation. And again, I would say a big percentage of patients I see with TMJ problem have a cervical component. Okay, so I think if you just start developing your own practice, you'll see the numbers. Okay, you'll see the statistics and the data as far as treating this patient population. Okay, so this is TMJ distraction. I'm gonna play the video now.
This is how we do a joint distraction of the left temporomandibular joint. I place my right thumb along those left-sided molar teeth. I tell her, Close down, don't help me, don't fight me, don't bite me. I palpate lightly her TM joint here, and I'm applying pressure down with my thumb towards the floor and a little tiny bit up under the middle of her chin. And your position is extremely vital. You must make sure the head stays in neutral, no side bendings, no rotations, no flexion, no extension, just neutral. And it's very gentle, very, very gentle pressure. I'm going down on my thumb, a little bit up under her jaw.
Okay, so that is TMJ distraction. So the component movements there is always going to be distraction, okay? So you're always going to distract the joint, okay? Slightly distract and then translate, okay? Don't forget the distraction part. What happens here is what happens if you just translate the joint. If you just do it that way, what happens? Potential damage to your disc. So again, that can be, again, not good for your patient who is already exhibiting a problem in the joint. Okay, so for again, like during our lab portion of our craniomandibular course, we're going to practice this on select participants only. Because again, I'm very careful because the TMJ, remember, is a very sensitive joint too. Okay, so if you do something, the amount of pressure that you do has to be really, you have to really practice all of these if you're practicing on a normal or a lab model without any, who have no symptoms, then it's fine, but you just have to be careful when we start doing this, okay? Or especially doing it on patients. All right, so this is TMJ translation.
This is for translation, to restore translation. I continue to palpate lightly the TM joint. I've moved my index finger around the angle of the mandible. So I'm going to be pushing down on the molar teeth with my thumb, but pulling the mandible a little bit forward, just a little bit forward. And I gently let it back and release up. Don't go down, forward, and then release. You might be too far forward and the patient could dislocate open. So be very, very gentle.
All right, your masseter release here. Again, this is more of a myofascial technique, which I've learned from Teresa as well. Again, there are several ways